Hi, my name is Ron Blankstein. I'm an associate professor in medicine and radiology at Harvard Medical School, the director of the cardiac CT program, and the associate director of the cardiovascular imaging program. For this talk, I will be talking about cardiovascular CT imaging. I have no disclosures relevant to this topic. The talk will consist of an overview of coronary artery calcium scanning. I will discuss how we perform coronary CT angiography because it is relevant for board exam preparation. I will provide a summary of some principles related to radiation dosimetry. I will discuss advantages and limitations of coronary CT angiography as they compare to functional testing. And lastly, I will also discuss how we use cardiovascular CT to evaluate valvular heart disease. When we talk about cardiac CT, there's now many different flavors. On one hand, we can do a coronary artery calcium scan. This is a quick and inexpensive scan that does not require any contrast, therefore patients do not need an IV. And we can use it to measure the amount of calcified plaque and provide the so-called Agatston calcium score, which is a highly reproducible measure of the amount of plaque, which has powerful prognostic data, which we will review. On the other hand, when we administer contrast, we can acquire a coronary CT angiogram, which can now show not just a calcified plaque, but also the non-calcified plaque. This is the scan we perform when we evaluate for obstructive coronary artery disease. Lastly, there's many other reasons why we may perform cardiac CT, and we can do a multi-phase acquisition where we acquire data throughout the entire cardiac cycle to create these cine movies, which allow us to evaluate not just left ventricular function, but we can also evaluate various cardiac masses. We can look at the function of valves, such as here, this movie showing a bicuspid aortic valve. And we can evaluate for things like endocarditis, which we will review later in the talk. Let's start first by talking about coronary artery calcium scoring. What we have learned from multiple studies now from several continents, including the MESA study performed in the US and the Heinz-Nixdorf recall study performed in Europe, that compared to individuals that have a calcium score of 0, those that have a severe amount of coronary artery calcium, defined often as a score greater than 300 to 400, may have up to a 10-fold increase in the risk of cardiovascular event over the next 5 to 10 years. That's a substantial increase in risk, which is much higher than any other risk factor or combination of risk factors that has been identified to date. Importantly, the risk that a calcium score portends adds on top of traditional risk factors. There's many different ways to look at this, but again, from MESA and Heinz-Nixdorf study, you can see in this slide the improvement in discrimination represented by the increase in the area under the curve, which is substantial in both studies, as well as an improvement in reclassification using the net reclassification index, again shown for both studies. Specifically in MESA, when we look at the intermediate risk patients, or at least what we used to call intermediate risk patients before the 2013 guidelines, 55% of them would be appropriately reclassified to a higher or lower risk group. There is really no other marker that can do this today. But while we've typically used calcium score to try to identify patients that have a significant amount of calcium who have higher risk, we have now realized that as important, or perhaps even more important, is the ability of a calcium score to identify individuals that do not have any plaque. Specifically, those that have a calcium score of 0 have a very low event rate, which in many studies approaches 0.1% per year. In fact, some work that we have done in this area has shown that you would have to treat 500 individuals for 5 years to prevent a single coronary heart disease event when you examine patients that have a calcium score of 0. So it's not that these patients would not have any benefit from treatment, it's just that their event rate is extremely low. So as a group, the benefit of treatment may be lower. Another way to look at this is to compare a negative calcium score with other measures of disease and to see how much they each can lower your risk if they are negative. So this slide here demonstrates the use of a negative likelihood ratio, and the more a bar goes to the left on this slide, the more it reduces your risk if that marker is negative. For example, a CRP less than 2, the absence of family history, or just having a healthy lifestyle. Of course, there's different ways to measure this. And you can see that all these bars certainly decrease your risk if they're negative, but none of them approach a 0 calcium score shown here in the blue bar. So given these findings, I think an important question that arose after the 2013 cholesterol guideline introduction is, what is the role of calcium testing now, specifically since these guidelines dramatically expanded the number of individuals who are eligible for statin therapy. Specifically, if a calcium score of 0 is reassuring and associated with a very low risk, one question that we asked is, if patients actually meet the statin guidelines introduced by the 2013 criteria, what is actually the chance that they in fact have a calcium score of 0? In other words, what is the chance that they have no evidence of calcified plaque and correspondingly a very low event rate? Well, among those who are recommended to be on statins, which included patients with an LDL more than 190, diabetics with an LDL more than 70, those that have a risk score using the pooled cohort equation of more than 7.5%, so these are all patients without known ASCVD. In the MESA study, all these patients who are recommended to be on statins by the 2013 guidelines, 41% had a calcium score of 0. And those who are considered to be statin candidates by the virtue of having an ASCVD risk score of 5 to 7.5%, nearly 60% of them had a calcium score of 0. When we combine these together, a rough estimate that we found is that nearly 50% of individuals who are actually recommended for statin therapy may have a calcium score of 0. Again, this is based on data from the MESA study. So the next question we can ask, in which patients is calcium testing most likely to impact management? Certainly this test is not necessarily useful for all patients. So in this illustration here, from a publication in JACC, we can see that patients that have a 10-year ASCVD risk of less than 5%, these are low-risk patients, irrespective of whether their calcium score is 0 or even if it's elevated, their 10-year risk is well below 5% and certainly well below the 7.5 threshold that we usually use to define who may be more likely to benefit from therapy. On the other end of the spectrum, if we look all the way in the right here, in patients who are recommended statin therapy and have a 10-year score greater than 20%, even if their calcium score is 0, their 10-year event rate is 11.7, and it exceeds our threshold of 7.5%. So both in these very low risk and in the high risk individuals, the role of calcium scoring really does not exist. On the other hand, the patients that have a risk score anywhere between 5% and 20%, those are the ones that if the calcium score is 0, the risk is reclassified low enough that we may choose to avoid statin therapy and instead focus on lifestyle therapies. If patients so choose, of course it's not incorrect to treat those patients if the guidelines so suggest, but this is where we use calcium scoring as part of shared decision making if those patients prefer not to be on statins. On the other hand, in these patients, if they do have calcium, their risk of events is higher, and in fact the risk of event could be sufficiently high that statins would be recommended. So based on this study and data in the field, the Society of Cardiac CT has put together this guideline suggesting where calcium scoring may be most effective. And to summarize, the key recommendation here is that it is appropriate to perform calcium testing in the context of shared decision making for asymptomatic individuals without clinical ASCVD And this is important because this is not a test that we do for patients with established disease. These are patients without clinical ASCVD who are 40 to 75 years of age and who have a 10-year ASCVD risk of 5 to 20%, and perhaps selectively in some individuals in the less than 5% group, especially if they have risk factors that typically are not captured by our risk calculators, such as a strong family history of premature CAD, or whether they have various inflammatory conditions that put them at a higher risk for having a premature CAD. So essentially, in the last couple of slides, I have summarized that we have seen an evolving role of calcium testing. We used to use this for screening low-risk individuals to detect who has coronary artery disease. And now, in the era where statins are becoming much more prevalent and certainly have a much wider role based on the 2013 statin guidelines, we now use calcium scoring selectively as a decision aid tool when patients, or perhaps when clinicians, are uncertain about a patient's risk, or perhaps a patient actually meets the criteria to be on a statin, but have a preference to avoid that if a calcium score may find that their score is 0, and as a result they have a very low risk, and they may choose to focus on lifestyle therapies. On the other hand, the same patients may choose that if they are found to have significant calcifications, which is in essence plaque, that they would be more likely to be on therapy. So a question that one can ask is, well, is there any data that shows that once individuals have a calcium score, that if they are found to have plaque, that that actually influences the patient behavior or the clinician behavior? This slide here shows the results of a meta-analysis of 6 studies where patients all had calcium scoring in various measures of lifestyle or pharmacological therapies were assessed and followed forward. And the summary here is that when calcium is identified compared to individuals that have a calcium score of 0, there was a higher rate of initiation or continuation of aspirin, lipid-lowering therapies, blood pressure-lowering therapies. Patients were more likely to have an increase in their exercise and also to have dietary changes. There are certainly some limitations of calcium screening that are important to mention. First, when we perform a calcium score, it cannot be used to follow the response to therapy. In other words, if patients have a calcium score of 120, we cannot expect that number to go down with treatment because the calcium is there to stay. In fact, there is some data suggesting that statins may slightly increase the calcium score. When we perform CT scans, such as when we do calcium screening, there is a small rate of finding incidental findings. This generally occurs 5 to 10% of the time. And at times these may be important findings, but at times they can be trivial pulmonary nodules, and the detection of such findings may create unnecessary anxiety for patients. Certainly there's been a change in the criteria regarding nodules that require follow-up, and it's important to know that many small nodules are completely benign. Calcium scoring is less useful in young individuals under the age of 35 to 40. And this is because in such individuals, they may have non-calcified plaque that has not yet had time to calcify. Finally, there are to date no large randomized trial data showing the value of calcium scoring. I think it's important to indicate that there's no such data for any other risk scores that we use in prevention. In fact, there has been in the past several large trials proposed, but they ultimately did not occur due to either funding issues or even ethical reasons. For example, it would be unethical to take patients that have a severe amount of plaque and we know have a high risk and randomize them to treatment versus no treatment. Similarly, if one were to design a trial comparing the use of calcium scoring to our prevention guidelines, that trial would be very challenging to do, as the current 2013 statin guidelines essentially dramatically expanded the role of statins So the majority of patients, especially if they are over the age of 60, would be suggested to be treated in such a trial. So a question that does come up is when patients are found to have elevations in their coronary artery calcium score, how should we treat them? And this is a table from the SCCT guidelines, but if I were to summarize these recommendations, the majority of patients who are found to have coronary artery calcifications should be on either moderate or moderate to high intensity statins. In patients that have a calcium score over 100, I think aspirin should be considered. There is some data showing that the risk of these patients is high enough that there's more benefit from being on aspirin than the harm that is associated with potential bleeding. It is important to know that when patients have a severe amount of coronary artery calcifications, there is never a need for invasive angiography. Some people have criticized cases where a calcium score leads to an invasive angiogram, but these are asymptomatic individuals, and even when a severe amount of calcium is identified, most of these individuals actually do not need further testing, and nobody would ever need an invasive angiogram. One can consider a stress test if there is a severe amount of calcium and it is unclear if the patient has symptoms or not, or perhaps they have a low exercise capacity and they don't really push themselves, so it's hard to know if they're truly asymptomatic. But for the majority of patients, the focus should be on medical therapy, not just medications, but also lifestyle interventions. Okay, let's shift our focus now to discuss coronary CT angiography. And in this slide, I summarize how do we actually perform this scan. First of all, we administer nitroglycerin to dilate the coronary arteries. With most scanners these days, we do administer beta blockers to lower the heart rate, as this is associated with better image quality. Patients need a good size IV. Because they require contrast, patients with renal insufficiency, especially a GFR less than 30 or contrast allergy, may not be able to have this scan. The scan is very rapid. When we acquire the data, some of the tricks are that the scan has to be timed exactly when the contrast is peaking in the coronary arteries, and there's various techniques for doing this using either what's called a bolus tracking or a test bolus. And we individualize the scan settings based on various clinical indications, as not all cardiac CTs are going to be acquired in the same way. When the images are acquired, we then spend several minutes reconstructing the images, meaning taking the raw data that's created by the scanner and actually creating the images. And finally, the interpretation of a coronary CT angiogram can range anywhere between 10 minutes for a very simple case to sometimes up to an hour if it's a very complex case. The interpretation is done on a 3D workstation, even though on this presentation, really everything I'm showing you is just images that are created from our 3D workstation. So still one of the attributes of CT is that when a scan is normal and we see no plaque and no stenosis, we can definitively exclude CAD with a very high negative predictive value, and this is associated with an excellent prognosis. On the other hand, when we do find disease, coronary CTA can identify the wide spectrum of disease. These are generally the categories that we use, ranging from minimal stenosis, which is less than 25%, mild stenosis, 25 to 49%, a moderate stenosis, which is defined as 50 to 69%, or severe stenosis, which is greater than or equal to 70%. And as you can see in these examples, there's different types of plaque. We generally describe the plaque as being calcified, non-calcified, or in this example here, partially calcified plaque. In addition to identifying the amount and the type of plaque and the severity of stenosis that it causes, there is now useful data on the identification of what we call high-risk plaque characteristics. The two most important ones are low attenuation plaque, which generally have a Hounsfield unit less than 30 units, or positive remodeling, also known as outward remodeling or Glagov remodeling. Another characteristic, probably less important than these two, is spotty calcifications. But importantly, patients that do have these high-risk characteristics are more likely to have cardiovascular events on follow-up, and also these characteristics have been associated with lesions that actually cause ischemia. Before we talk more about coronary CTA, for the next couple of slides, I do want to turn our attention and talk about some radiation principles that may be important for your board preparation. The first principle, well known to all of us, is the ALARA principle, which is that we should aim to achieve a radiation dose as low as reasonably achievable. It's also important to know the linear non-threshold principle, which states that although no clear evidence exists to link radiation received from medical imaging with malignancies, radiation protection philosophy assumes that even small doses of ionizing radiation may be associated with increased risk. This is the most conservative principle when we describe radiation principles, but because of this, it certainly follows that we should always try to achieve the ALARA principle. Two other terms that are important when we discuss radiation are the effects of radiation, and they generally can be divided to stochastic effects and deterministic effects. Stochastic effects are the ones that we are generally most worried about when patients are exposed to too much radiation because they have many images every year. These effects are increased with higher dose of radiation. The latency period it generally takes between 10 to 30 years, and these are the effects that generally cause malignancies. On the other hand, if a patient is exposed to a very high dose in a single procedure, and this typically happens from long-term invasive procedures, even though this is rare, are effects that the severity increases with the dose, and the example here is skin burns and erythema. Whenever we describe the radiation dose in order to compare different modalities and different techniques, the best term to use or the best measure is the effective radiation dose. This measure, which generally we measure in terms of millisievert, and for cardiac CT it can range anywhere between 0.5 to 20 millisieverts on some of the older scanners before we use various radiation saving techniques. But this effective dose takes into account all of the organs that are exposed, as well as their corresponding sensitivity to radiation-induced changes. And again, the effective dose is useful for comparing different scanners. So for the purposes of comparison, the typical background radiation dose in North America is 3 millisieverts per year. The limit for medical professionals, such as many of us and technologists, is 50 millisieverts per year. And then an interesting comparison is that the level of radiation recorded at the Japanese nuclear site on March 15, 2011 was 400 millisieverts per hour. So if we are going to compare various cardiovascular imaging tests, among the nuclear tests, PET has the lowest radiation dose, both for ammonia and rubidium, around 5 millisieverts, calcium score 1 to 2 millisieverts. A full cardiac CT or coronary CTA can range anywhere between 2 millisieverts to 10 millisieverts. A nuclear SPECT MPI, generally higher, ranges between 8 to 12 millisieverts when we use a single isotope study, and certainly this is higher if you use dual isotope with thallium. An invasive angiogram, generally around the same range of a cardiac CT, especially if it does not involve taking pictures outside of the coronary arteries. There are various techniques that have now resulted in a dramatic reduction in the radiation dose associated with cardiac CT. I'm not going to go into too much detail, but it is important to know that currently most cardiac CTs that achieve a low dose use what's called an axial acquisition using prospective ECG triggering. And when this is used, the X-rays are essentially only delivered at pre-specified portions of the cardiac cycle, typically in diastole, and they're completely turned off in other portions of the cardiac cycle. This is as opposed to the helical acquisition that typically, in older studies, did not involve any tube current modulation, where X-rays were delivered throughout the cardiac cycle. So this is where the radiation dose used to be much higher. Let's now turn our attention and discuss what are some of the indications for coronary CT angiography. Well, they include the evaluation of both acute and stable chest pain, evaluation of patients that have suspected anomalous origin of the coronary arteries, evaluation of bypass grafts, and in some cases, evaluation of large stents. I generally would recommend 3 millimeters and above because very small stents will be more difficult to visualize. So to frame our discussion, here is a case of a 52-year-old male with mild exertional chest discomfort who has hyperlipidemia. This is the ECG of this individual. And we performed a coronary CTA on this male, and here are the results. We identified that here in the LAD, there is a moderate stenosis, which again is defined as 50 to 69%. In this particular lesion, because we're using a 3D workstation, we can look at it en face. So in what you can see here is the contrast-filled lumen. And all the way around it, we can see a large amount of non-calcified plaque. There's no calcium here. In fact, this would be an example of positive remodeling as well. So one of the challenges, and this is true not just for CT angiography, but also of invasive angiography, is that when we see a moderate lesion, it is very difficult to know, is this associated with stenosis? In fact, when we looked at this in a review from several years ago, in 6 different studies of patients that underwent both CT angiography and nuclear imaging, in this slide we see the positive predictive value in blue and the negative predictive value of red of a 50% stenosis for identifying whether ischemia was present or absent. And you can see here, while the negative predictive value for ruling out ischemia is high, the positive predictive value of a 50% lesion for determining whether ischemia is present or absent is only at best 50%. This is not unique to CT angiography. If we look at invasive angiography and now use FFR as the reference standard, it is notable in the FAME study that lesions that anatomically were between 50 and 70%, 65% of them actually had an FFR more than 0.8, thereby being non-flow limiting. And even individuals that had more than 70% stenosis, 20% of them were not flow limiting by FFR. So I think the takeaway point here is that anatomy alone, especially when we see moderate stenosis, is inadequate of telling us whether ischemia is present or absent. So how can we figure this out? Well, one thing we can do, such as in this case, is a patient that has a moderate stenosis, we can now refer them to a functional test. In this particular case, this patient actually underwent a nuclear study, and that showed no ischemia, so we can be reassured that this lesion is not associated with any ischemia. So that may be a limitation of CT angiography, that these moderate lesions that may be present between, depending on the type of patients enrolled, between 10 to 20% of the time, that you may not know if these are flow limiting. On the other hand, what if this patient was actually first evaluated with a nuclear study, the study on the right here? In fact, that's what occurred in this particular case. This patient had a nuclear study. It showed no perfusion defect, but he did have some atypical chest discomfort while he was on the treadmill. And the challenge is that when you do a nuclear study and it's normal, well, that is very reassuring in most instances. It does not detect a non-flow limiting CAD, and in this particular patient who was not on any medical therapy, the determination of plaque, even if it's not flow limiting, may be very important in implementing preventive therapies. So certainly you can see that there's both advantages and limitations of both techniques here. Now, another possible option, if we see this patient who has a moderate stenosis, that I think we may see more of in the future, is to perform what's called CT FFR. So this is a technique now where we use computational fluid dynamics to actually estimate, based on the REST CTA images, what the FFR is at this particular location, without giving any vasodilators, just based on the REST CTA images. There are several vendors that can perform this, but at least one of the vendors, the leading vendor in this site now, does require sending the data to a vendor that will then do this determination, and the information that would be returned to the site would be that the CT-FFR here is 0.85, thus establishing that this is not flow limiting. So to date, there's been several studies that have actually compared what happens if we were to take a patient with stable chest pain and randomize them such that half would get CTA first and half would get functional imaging. And this is a slide that compared the results of several of these studies, both randomized trials, which were the PROMISE study in the US, the Scott Hart done in the UK, in the CAP study, as well as recently a large registry known as the Danish registry. And one of the findings from all these studies, when we put this together, whether in a meta-analysis of the 3 randomized trials or in the Danish registry shown here in red, is that patients randomized to CTA generally were found to have a reduction of approximately 30% in the future rate of myocardial infarction. And certainly we can speculate why that is, and one possible reason is that CTA leads to a higher identification of plaque, even if it's not flow limiting, and that was associated with a higher initiation of preventive therapies, both statin and aspirin, as you can see in this summary slide. On the other hand, patients that were randomized to coronary CTA, however, were also found to have a higher rate of coronary revascularization compared to those who were randomized to functional testing. In fact, this slide shows data from our meta-analysis on this topic, showing that patients randomized to CTA had a 33% higher odds of undergoing invasive angiography and a 77% higher odds of undergoing coronary revascularization. Now, because there was no significant difference in outcomes, at least hard outcomes in these patients, it suggests that perhaps some of these may have been unnecessary procedures. On the other hand, there was a reduction in myocardial infarctions, and while many people would argue that that was all because of medical therapy, some have suggested, could some of these revascularizations have led to the reduction in myocardial infarction? The reality is that we just don't know based on the current data. But I will also point out the potential overuse of invasive angiography and coronary revascularization may have resulted because many sites in these trials, many of whom were relatively new in the field of cardiac CT and a lot of data wasn't available yet, may have not known yet how to actually deal with the various findings. And since these trials have been conducted, there has been more guidance, specifically a document known as the CAD-RADS. RADS stands for Reporting and Diagnosis System. And the CAD-RADS document has now provided more guidance on how should we actually act on the results of coronary CTA results. This is important to review in that patients that have no plaque or stenosis, a CAD-RADS of 0, should be reassured. Their prognosis is excellent. Patients that have non-obstructive disease, that's the CAD-RADS 1 and 2 with minimal and mild stenosis, really only require preventive therapies. They don't need any further testing. Patients with moderate stenosis, such as the example I just showed you, actually do not need invasive angiography, which may have been done in some of the trials, but instead functional testing in order to determine whether those lesions are flow limiting. And it's only patients that have severe stenosis, which is more than 70%, that some of them could be considered for invasive angiography. Specifically, the CAD-RADS 4 classification recommended invasive angiography only in patients that have left main disease more than 50% or 3-vessel obstructive, i.e. more than 70% disease. And in fact, most patients with severe stenosis could have either an invasive angiogram or functional assessment. So perhaps the most important take-home point from this slide is that non-obstructive disease warrants preventive therapies. Moderate stenosis, 50 to 69%, warrants functional assessment, not invasive angiography. So in this slide here, I summarize some of the principles we discussed, which are the strengths and limitations of coronary CT angiography. The strengths are that CTA can detect the presence of CAD, but also identifies a whole spectrum of disease ranging from non-obstructive plaque to significant stenosis. CTA is a very rapid exam. It is readily available now in many centers. The limitations are that the accuracy can be reduced if there's significant amount of coronary calcium, resulting in what's called calcium blooming artifacts, or if the image quality is limited. The physiologic significance of some lesions, especially moderate stenosis, is unknown, and the specificity of knowing whether those are associated with ischemia is reduced. The image quality can also be reduced in patients that have elevated heart rate. This is why we often give beta blockers. Certainly some of the newer scanners, especially dual source CT scanners, can now provide very good image quality even when the heart rate is elevated, but it comes to a point that if the heart rate is significantly elevated and a patient could not receive beta blockers, that the image quality will suffer. And finally, patients that have morbid obesity, depending on your scanner, this maybe you'll get reasonable images with a BMI up to 40 or 45, but generally once patients have a BMI more than 40, image quality will be reduced. Before we proceed to the next portion of the talk, I do want to review some data regarding the prognostic value of CTA findings. And I think this is important because in the past, when CTA was first introduced, many people debated whether the detection of non-obstructive disease, which after all is one of the advantages of CTA, or potential advantages, whether that's prognostically important. In other words, if we just see some plaque that's not obstructive, is it really that important to identify that? Well, one of the first studies that looked at this from the CONFIRM registry looked at all-cause mortality and showed in this large study of over 23,000 patients that non-obstructive disease is associated with worse survival compared to patients that have normal CTA. Another study that looked at this from the Partners registry that we ran at Brigham and Women's Hospital showed that extensive non-obstructive CAD has a similar risk of heart events, specifically CV death or MI, as obstructive CAD. And in this study, we took all the patients that have non-obstructive plaque and divided them as those that had less than 4 segments with plaque. That's known as the segment involvement score less than 4, or those that had a segment involvement score of 4 or greater, meaning at least 4 segments had plaque. And you can see here in the pink line is that if patients had 4 or more segments with plaque, their event rate actually was very similar to patients that had obstructive CAD. And again, these are heart events, CV death or MI. This does not include revascularization. And these findings suggest that it's not just whether you have plaque or not, but the more plaque that individuals have, the higher their risk of events. Perhaps these findings should come at no surprise, but I think it's also important to note that similar findings have now been shown in patients undergoing invasive angiography. Specifically, in this study from the VA, looking at a large cohort of patients that underwent elective invasive angiography, the identification of non-obstructive CAD was associated with a significantly higher 1-year risk of MI and all-cause mortality. And as you can see here, the greater the extent of plaque, the higher the risk. Another indication where coronary CTA is used increasingly often is following an inconclusive functional test, such as in this example, an inconclusive SPECT myocardial perfusion imaging study. This particular patient only demonstrated mild ischemia. However, they had typical chest pain while they were exercising. And as a result, the patient was actually recommended to undergo invasive angiography, which they preferred not to do, and instead a CT angiogram was performed. The CT angiogram demonstrated left main stenosis, and this is one of the examples showing that SPECT perfusion imaging generally underestimates the extent of disease and at times the severity of disease because of the phenomenon of balance ischemia, where we generally are looking at relative differences in blood flow. So again, another example here of when coronary CTA may be useful after an inconclusive functional study. Certainly in some of these cases, if the risk of having disease is incredibly high, proceeding directly to invasive angiography may be appropriate. But in many of these cases where a functional study is inconclusive, the risk of having high-risk disease or the likelihood of having high-risk disease is low enough that a CT angiogram may be a useful test. I talked a lot about stable chest pain, and it is important to mention that coronary CTA is increasingly being used in the emergency department. To summarize some of the data, I wanted to provide the highlights from the 2014 AHA-ACC guideline for the management of patients with non-ST acute coronary syndromes. In this document, in their summary, state that coronary CT angiography is associated with rapid assessment, high negative predictive value, decreased lengths of stay, and reduced costs. So these are all the attributes of using CT angiography in the emergency department. However, when we evaluated in the meta-analysis the 4 randomized controlled trials where patients in the emergency room were randomized to a CT angiogram or to undergo usual care, we find that compared to usual care, the use of CTA is associated with a small increase in invasive angiography, approximately 2% higher rate of using invasive angiography, and also a 2% higher risk of undergoing coronary revascularization. So these are findings that are fairly similar to what we saw in stable chest pain, that there are certainly advantages of the use of CTA in this setting, and we can identify more plaque, we can acquire the images and get the results and establish a diagnosis rapidly. However, when we do use CTA, there is a higher use of these invasive procedures. Another area where coronary CTA is useful is for evaluating patients with congenital heart disease. I should say not just coronary CTA, but cardiac CT. One of the areas that's very important is the evaluation of patients with anomalous origin of the coronary arteries, but even for patients with complex adult congenital heart disease, CTA is considered appropriate. When we look at patients that have anomalous origin of the coronary arteries, it is important to recognize that the vast majority of these anomalies are completely benign, and as such, they do not require further testing. As an example, the most common anomalous origin of the coronary artery that we see is when the left circumflex arises from the right coronary cusp and has a retroaortic course. Retroaortic means behind the aorta. It's generally not prone to any compression here, and it just basically takes this turn before it reaches its normal location. There may be a higher risk of having atherosclerosis in some of these vessels because of the tortuous course. On the other hand, another benign variant is patients that have a prepulmonic artery, so such as a prepulmonic LAD, where the vessel now courses anterior to the pulmonary artery. So this is again not prone to any compression. The more concerning variants are when you have a vessel that runs in between the great arteries. This is known as an interarterial course. In this particular example here, we can see a right coronary artery that arises from the left cusp and traverses between the pulmonary artery and the aorta. When we look on short axis imaging, we can see this oval-like projection of the right coronary artery. When this is accentuated, sometimes we would describe this as a slit-like orifice, and this is a higher risk subtype because there's a potential for compression between the great vessels. And perhaps one of the more challenging aspects is how we deal with a patient that has an anomalous right coronary artery, because some of these can be incidental findings in asymptomatic individuals. But in general, patients that have symptoms or patients that have ischemia are going to be at even higher risk of events. And in some of those patients, especially if they are young, consideration for a repair such as unroofing may be performed, but certainly is not needed for all these patients. Another challenging entity, and probably the highest risk of all of these, is when patients have an interarterial course of the left main. So at this point, the left main takes off from the right coronary cusp. It traverses between the aorta and pulmonary artery before reaching the normal location of the left main. And in this particular example on the right side here, there's clearly compression of the left main between the pulmonary artery and aorta. What we can see is narrowing of the proximal segment of the artery. So this is the highest risk, albeit a rather rare variant, and these are individuals that would benefit from a procedure to correct this. On the other hand, there's another variant that looks a lot like this that is associated with a lower risk, and that is what's called a transseptal course. Here we actually see the left main again arising from the right cusp, but instead of traversing between the aorta and pulmonary artery, it traverses between the aorta and the right ventricular outflow tract. We don't see the compression here, and certainly there may be some risk associated with this variant, but it's not as high of a risk as the true interarterial course. Let's now turn to the last part of the talk, and that's assessment of valvular heart disease. When we use cardiac CT, I've already mentioned that we can perform a multi-phase acquisition. We can look at, for example, the aortic valve, and here we see an example of aortic valve stenosis in a valve that's actually not all that calcified. On the right, we see an example of a bicuspid aortic valve. And when we try to determine the severity of stenosis of an aortic valve, one way to do this is to look at these cine images. Another method is to actually perform a calcium score of the aortic valve. And in this study here from Clavel and colleagues, in fact 2 studies, we see that the use of a calcium score has a fairly high sensitivity to establish severe stenosis. But you should note that there's different threshold for women and men. For women, a calcium score of 1274 for the aortic valve, for men 2065. But these may be useful measures in individuals where the severity of aortic stenosis may be uncertain, and this may be helpful at differentiating a true severe aortic stenosis from pseudo-AS. CT is also useful for evaluating prosthetic valves, especially since many of these valves cannot be adequately evaluated with echocardiography due to various artifacts. In this slide here, we see an example of a thrombus involving a mechanical valve. This can be evaluated with fluoroscopy in the cath lab, but CT is another very good technique to see whether a mechanical valve is opening or not, and we can directly visualize thrombus in this particular valve in a patient that should have been anticoagulated. CT has also been shown to have a high accuracy of identifying endocarditis, both in native valve and in prosthetic valves. And this example in this slide shows on the top row the CT images, on the bottom row corresponding TE images. Certainly TE has a higher resolution for some of these lesions, but in a patient who cannot undergo a TE, or sometimes if there's inconclusive findings after a TE, CT may be useful for evaluating endocarditis. And CT is useful here not just for showing vegetations, which at least in one study the accuracy of vegetations was very high when compared to TE, but CT can show other abnormalities in the valves. In this particular example, we can actually see a perforation in the aortic valve leaflet in a patient that had severe aortic regurgitation, and this is a perforation resulting from endocarditis. Another thing that we've learned to recognize that's associated with endocarditis is structural abnormalities in a valve, such as this particular case here, that does show a pseudoaneurysm. So this is a pseudoaneurysm of the left ventricular outflow tract. So right where this blue line is in the left ventricle below this bileaflet mechanical valve, we can see a small outpouching of contrast that's well well encircled here. This is a pseudoaneurysm of the left ventricular outflow tract, and in the appropriate setting, this certainly should raise the suspicion for endocarditis. We use cardiac CT more and more for planning for various structural heart disease procedures, especially TAVR. I've already talked about how calcium score may be useful for assessing the severity of aortic stenosis and how our cine images may be useful. But we also use cardiac CT to evaluate the size of potential devices. Specifically, cardiac CT provides measurements of the basal ring or LVOT annulus that we can see here. And an important limitation of other techniques is that this basal ring is actually oval in shape, it's not round. So to really get the true measurement of this annulus, a 3D modality such as CT would be preferable. CT can also predict various complications, and while I will not go into them for the purposes of this particular talk, there are various studies showing how the use of CT can be used to predict perivalvular regurgitation, coronary osteocclusion, and here you can see on the bottom right how we measure the height of the coronary arteries for certain devices, aortic rupture in patients that have porcelain aortas, or even conduction abnormalities. So these are all complications of TAVR that may be predicted with the use of cardiac CT. One procedure that we're seeing more and more of is TMVR, or transcatheter mitral valve replacement, and an important role of CT is for projecting that if we put a valve in the mitral position, what would that do to the flow across the left ventricular outflow tract, demonstrated here by the blue dashed line. And specifically with CT, what we now can measure is the area of the neo-LVOT, the new left ventricular outflow tract that would be projected to occur if we were to put this big valve in the mitral position. And based on these projections, we can identify patients that have too high of a risk of obstruction where a TMVR procedure would be contraindicated. As we're putting more and more of these valves, specifically in this example, TAVR valves, we have learned that CT is also useful for identifying this entity known as HALT, hypoattenuation leaflet thickening, which we have come to realize represents, in many cases, subclinical thrombus. However, it's not just subclinical because these findings of HALT, which you can see in this patient on the left side here, have been associated with an increased risk of TIA. Fortunately, when these are identified when patients are being treated with anticoagulation, such as this patient on this slide, when we repeat the imaging later, both based on our own experience and that of others, this seems to go away. So these lesions are highly responsive to the use of anticoagulation. So we've covered a lot of material, and in this slide I wanted to summarize some of the main take-home points. We'll summarize 4 points. First, calcium scoring may be useful in selected asymptomatic patients who do not have established ASCVD when the decision regarding the role of statin therapy is unclear, especially in those with age 40 to 75 who have a 10-year ASCVD risk score of 5 to 20%. When we do find significant calcium, it's important to implement aggressive preventive therapies, both pharmacological therapies and lifestyle therapies, but it's important to recognize that the vast majority of these patients do not need more testing. The second point is that coronary CTA is useful for evaluating both acute and stable chest pain patients who do not have prior history of CAD. I showed you some data that in the stable chest pain patients, there is a reduction in the rate of myocardial infarction in the trials that compared patients who underwent CTA versus functional testing. On the other hand, when patients are randomized to CTA, there is an increased risk of invasive angiography and coronary revascularization in most, but not all studies. The last point is cardiac CT is increasingly being used to evaluate patients with valvular disease. We can now use CT not just for planning for TAVR and TMVR procedures, but also for patients that have suspected endocarditis, especially if they have mechanical valves, because those are ones that cannot be easily imaged with echocardiography. Let's now do 3 board review questions. I will first show you the question and we will then discuss the answer. Question number 1. Which of the following represents a strength of coronary CTA when assessing patients with stable CAD? A. In comparison to functional testing, the use of CTA allows for the identification of non-obstructive coronary atherosclerosis. B. In comparison to functional testing, the use of CTA is associated with less invasive angiography. C. In comparison to functional testing, the use of CTA is associated with less coronary revascularization. D. In comparison to invasive angiography, the use of CTA is associated with lower contrast dose. Well, the correct answer here is A. Indeed, when we compare to functional testing, CTA does identify non-obstructive plaque, which functional testing is not designed to identify. And this may be advantageous if those patients were not on medical therapy, and CTA allows us to institute such therapies. When we compare CTA to functional testing, CTA is actually associated with a higher rate of both invasive angiography and a higher rate of coronary revascularization. In our talk today, I explained some potential reasons for this. And finally, invasive angiography and CTA tend to have a similar amount of contrast. If anything, invasive angiography, if only selective images are obtained, may be associated with a lower contrast dose, not CTA. Question number 2. A 58-year-old male with history of hypertension was found to have a calcium score of 232. He exercised daily and has no symptoms. There is no family history of premature CAD. His ASCVD risk score by the pooled cohort equations is 7.1%. He is not on any medical therapy. Which of the following statements is correct? He has moderate amount of coronary artery calcifications and would benefit from statin therapy. He has moderate amount of coronary artery calcifications and should undergo invasive angiography. He has moderate amount of coronary artery calcifications and should undergo exercise treadmill testing with or without imaging. Or D, his 10-year risk is less than 7.5%, and thus he would not be a candidate for statin therapy at this time. The correct answer is A. He does have a moderate amount of plaque and would benefit from statin therapy. Even though his ASCVD risk score is 7.1%, the identification of calcium would portend a higher risk, and he certainly would have a risk that's higher than the 7.5% threshold. Choice C would be incorrect because most patients like this who are asymptomatic do not need further testing, such as an exercise treadmill test, regardless of not whether imaging is done. Choice D would be incorrect. It's true that if his 10-year risk is less than 7.5, he is not a candidate for statin therapy, but he is someone in whom statins would be suggested, not recommended, but suggested for consideration. And the guidelines clearly state that when the decision regarding the role of statins is unclear, calcium scoring is a potential test that can be used for further decision making. So the guidelines actually do provide a role for using calcium scoring in this particular situation. Question number 3. Below coronary CTA images are from an asymptomatic 32-year-old female with family history of sudden cardiac death. What's the diagnosis? A. Left main arising from the right cusp was interarterial course, was transseptal course, was a prepulmonic course, or was a retroaortic course. The correct answer here is a transseptal course. What we can see here is that this anomalous left main course is well below the pulmonic valve, and I put here using this yellow line where the pulmonic valve typically would be. So this is below the pulmonic valve here, and this is a transseptal course where the left main course is between the right ventricular outflow tract and the left ventricle. And while this is important to recognize, this is likely a lower risk variant than patients that have a true interarterial course. This slide provides several references for our talk.